Hi, good afternoon, everyone. Let me just introduce myself. I'm Dr. Samir, like he said. Now, I come from this beautiful university, the Gulf Medical University, which is based in United Arab Emirates. This is in Ajman. Dubai, you must have heard, the city which has got the largest, tallest, everything possible now. So this is how a university works. Now, today I'm going to talk about early treatment in orthodontics. Now, early treatment in orthodontics, as Bishara rightly said, it is a treatment which is started during the primary or the mixed dentition. Now, generally when we associate orthodontics, it is associated with treatment in adults or after the mixed dentition. But what happens is a lot of problems get worsened if they're left after the mixed dentition. So the concept is changing from doing it after the mixed dentition to starting from the primary dentition itself. So according to Bishara, the early treatment is, which is the treatment started in primary or mixed dentition phase that is performed to enhance the dental and skeletal development before the eruption of permanent dentition. Its purpose is to either correct or intercept malocclusion and reduce the need of time for treatment in the permanent dentition. Now, firstly, the preventive early treatment is started during the primary dentition itself. That is like patient education of stopping the digit sucking habits, the space maintenance appliances. And then coming to the interceptive early treatment, that is the primary tooth guided extractions like the serial extractions. Reducive, that is the reduction of excess overjet, and the corrective treatment, which is done after the growth is over. Now, it can be also called as phase 1 and phase 2 of treatment. Phase 1 is the treatment initiated during the primary or the mixed dentition with the purpose to prevent, intercept, or correct an orthodontic problem, also known as early treatment. Whereas phase 2 is the treatment initiated during the permanent dentition with a comprehensive approach to correcting the orthodontic problems, also known as comprehensive treatment. Now, what are the specific goals of the early treatment? First is the improved psychosocial development. In today's age of Facebook and Twitter, every facial expression you take, every bite of burger you take, it is downloaded in Facebook. So the children are so obsessed right from an early age with their looks. So imagine if they have to wait till 12 years with their protruded teeth, with spacing, the kind of impact on their psychology. So it improves the self-esteem, and the most important thing is aesthetics. Then secondly, not only for looking good, for improved occlusal function as well, for the symmetry, shifts, slides, attrition of teeth, manage potential for damage to dentition. There can be damage to dentition, especially in cases in which overlapping of teeth is there, or single tooth and anterior cross bite. So it can cause the damage to both the teeth. Then it simplifies phase 2, and it improves or corrects the skeletal discrepancies. Now, if you can look at the flow chart, this is what the phase 1 treatment does. But there are certain risks associated with it. Most important thing is the diagnosis of a case. If the diagnosis is not done correctly, it can go reverse. It can be, instead of correcting, it can actually worsen the problem. So misdiagnosis is a big risk. Extended treatment time, patient burnout. The patients are exhausted because they've started treatment during the mixed dentition, but the fixed phase has to be done. So 6 years or 7 years of continuous orthodontic treatment, the patient compliance becomes much lesser over a period of time. And there are increased chances of caries. Now, what is the best time what is the best treatment timing? So as suggested by Janali, the late mixed dentition offers the best time for intervention, especially because the spaces still exist. Approximately 80% of the patients are still treatable by non-extraction, and the treatment can be completed in one phase itself. Now, to prevent an unnecessarily extended treatment, now it prevents patient burnout, reduce jeopardy of oral tissues. Now, what are the non-skeletal orthodontic issues which can be corrected at an early age? First is the crowding, anterior cross bites, and eruption disturbances. The crowding, the treatment options for moderate and severe crowding in the mixed dentition depends upon preventing irreversible damage, promoting eruption of teeth into attached gingiva. That's very important. Class 1, Class 2, or Class 3 dental and skeletal growth pattern, incisor proclination, midline shifted or centered, aesthetics. Now, options is, firstly, to maintain the current arch perimeter or increase the arch perimeter. Now, this is, if you can see an example of a lower lingual holding arch, it holds arch perimeter as the permanent tooth erupts. You can see there is a missing deciduous teeth, so that the permanent tooth doesn't move forward. A lingual holding arch has been placed, so the space is maintained. Now, for severe transitional crowding, that the signs are lack of interdental spaces in primary dentition, greater than 4 mm of crowding of the permanent incisors, and ectopic eruption of the upper first permanent molars. Now, this is a very controversial topic of serial extraction. Some people advocate it, some people don't advocate it. Serial extraction is a planned and sequential removal of certain deciduous and permanent teeth in order to promote eruption of teeth through the attached gingiva and reduce the severity of crowding. These are the ideal case selection requirements for serial extraction. The timing of extraction is half to 3/4 root development of the first permanent molars to accelerate eruption. The sequence which we follow is CD4. That is the C, D, and the first premolar. Now, coming to the anterior cross bites, you can see a single tooth anterior cross bite is there, in which there is lingual eruption of a maxillary incisor relative to the mandibular incisor. This is with or without a shift. Traumatic occlusion is possible, and lower anterior recession is possible. If you can see, especially in the lower picture, there's a recession of the lower anterior. Now, coming to the ectopic eruption of maxillary first molar. Ectopic eruption is a developmental disturbance in the eruption of the permanent dentition, where the first permanent molar erupts with the mesial angulation and resorbs the distal root aspect of the primary second molar. What happens because of this? The deciduous second molar resorbs at a much faster speed and gets exfoliated. Now, this is one of the appliances which we can place. In this, you can see we are taking the help of the second deciduous molar to push the first molar, permanent molar, distally. Now, the presence of supernumerary teeth like a mesiodens, it causes delayed eruption of incisors, a diastema, excuse me, severely displaced incisor, ectopic or asymmetric eruption of the central incisors, and erupted supernumerary. Now, ankylosed primary molars also cause delayed eruption of teeth. Now, coming to skeletal orthodontic issues, it can be transverse problems, vertical problems, and the growth modification. The transverse problems in the mixed dentition are posterior crossbite. If you can see, there is a posterior crossbite when the upper teeth bite on inside of the lower teeth. So what we do, we can do arch expansion. According to McNamara, it can be used to correct transverse and sagittal crossbite problems and to provide sufficient arch space to resolve borderline crowding in some mixed dentition patients. These are the examples of expansion appliances like the Hyrex appliance and the bonded expander. Now, habits, whether it is a thumb sucking, digit sucking, or your tongue thrusting, nail biting, these habits all have a deleterious effect on your dentition. So these are some of the examples of habit-breaking appliances: anterior crib appliance, the bluegrass appliance. Now, the skeletal open bite, early treatment can be carried out with various appliances like the partial braces, high pull headgear, the chin cup, the transpalatal arch, and the lower lingual arch. This is the example of a lower lingual arch, and this is the example of a transpalatal arch. The vertical problems like a deep bite can also be corrected in the mixed dentition. We can give an anterior bite plate, as you can see on top, and partial braces like the 2x4 appliances. Now, the growth modification appliances, the treatment for class 2, class 3 skeletal problems with the intent to alter unacceptable skeletal relationships by modifying the patient's remaining facial growth to favorably change the size or position of the jaws. These growth modification appliances are of great use, especially in class 2 and class 3 malocclusion, in which later on the only treatment can be surgery. So if something can be done at an early stage, as Dr. knows here, he's an oral surgeon, so if this can be prevented at early stage, I'm not saying it can be prevented altogether. Maybe the patient has to go for surgery, but the extent of damage done will be much lesser with the use of the growth modification appliances. Now, the class 2 growth modification appliances, I will show it to you. There's some of them. For the orthopedic appliances, we have headgears, function appliances, and for the dental appliances, we have the pendulum appliances and the partial braces. Now, these are the headgears, are the orthopedic appliances. As you can see, it can be occipital combination pull and the cervical pull headgear. I'll show you some of the cases in which for the class 2 correction it has been done. This is before treatment. This is with the headgear. This is after the treatment, only with the headgear. There is no fixed treatment involved in this. This is only with the use of headgear appliances. This is another case with the headgear, and this is after. Your molar relationship is corrected. Now, the other orthopedic appliances which are used for class 2 modification are the function appliances. An example of that is a bionator. There are fixed ones also. Bionator is a removable one. We have fixed appliances which can be Herb's fixed appliance. This is, you can see how it looks in a patient's mouth. Then we have dental distalizers like a pendulum appliance, appendix appliance. Now, class 3 growth modification treatment appliances. It can be both skeletal orthopedic options and dental options. Skeletal options are protraction face mask plus RME, chin cup, and the dental options are the expansion appliances and the 2x4 appliances. This is the example of a protraction face mask with RME. You can see the face mask, and this is the RME. These are the hooks on the lower photograph with which elastics are put and is attached to the face mask. Now, to summarize, for a 7-year-old, first orthodontic evaluation, supernumerary or missing teeth, check for them, the growth pattern, the eruption schedule. Then for 8 years old, check for the degree of crowding, posterior or anterior cross bite, class 1, class 2, or class 3. Check for the deep bite, open bite, and habits. 10 years, look for the permanent canine position. 11 years, and check for the late mixed dentition. 7 to 10 years, possible need for the phase 1 treatment. And after 11 years, possible need for phase 2 or comprehensive treatment. These are the references from which this lecture has been prepared. Now, this is my beautiful hospital. These are some of the patients. And this is the waiting area for our dental teaching clinics. So I just wanted to show this is a very luxurious clinic in which students work. This is just a waiting area for the patients to sit here. And the clinics all around, they have a separate waiting area for children, separate clinics for pediatrics, women, considering the regional sensibilities. So this is a beautiful hospital. This is my hospital where I work. Thank you very much.
Thank you.